Okay, guys, let's talk about upper respiratory disorders. And I'll try not to. Okay, first we're going to talk about upper respiratory trauma obstruction. So, what is the epistaxis? Basically, when we're talking about this, we're talking about bleeding from the nose. It could be brought on because of trauma, dry mucus. Remember, we talked about that when people are in the hospital and on oxygen, how they will dry up if we don't humidify the oxygen, and that could lead to some not only pain for the patient, but it can lead to infections due to the fact that that's so vascular, and bacteria just love it. Infection, substance abuse. What kind of substance do you think? Basically anything you snort up your nose that's not supposed to be there, right? So usually we think of cocaine, but anything like methamphetamine or I don't know what else people shoot up their nose. But whatever's not supposed to be there, let's even talk about huffing. When people are huffing, paint and aerosols, things like that. Hypertension. A lot of times hypertension, whenever they have that malignant hypertension that we talked about in the cardio section, their nose will bleed. That shows that it is a high blood pressure. They might have some headaches along with that, but a nosebleed is definitely one of them. Bleeding disorders like low platelets, that could be a problem, or treatment with anticoagulants. Remember, when we're treating with anticoagulants, warfarin, Eliquis, Pradaxa, even heparin and Lovenox, we have to look for any kind of bleeding signs. Not only are we talking about hematuria and possible occult blood in the stool, but we're also talking about bleeding from the nose. Remember, the nasal passages are very vascular. That's why nowadays they are doing Narcan up in the nostrils. Before it was I believe it was an IV or an IM injection. Now we're doing it in the nose. There are some other aspects that we put in the nose also. Funny thing is, I think about my dog with the Bordetella. They used to do Bordetella shots for dogs before they go into kennels so they don't get the Bordetella cough, but nowadays they put it up in the nostrils. Interesting, huh? Goal of the treatment is identify and control the source of bleeding. The funny thing is, we talk about substance abuse and the fact that cocaine going up the nose or anything going up the nose can stop or it can cause epistaxis. But whenever we have surgery and they do like a rhinoplasty or anything, a roto-rooter of the sinuses, they used to use cocaine. And why do you think they would use cocaine to stop the bleeding? This is when I'm sitting in the front of the classroom just looking at you guys. The reason they would use cocaine because cocaine is a vasoconstrictor. So they shoot some cocaine up your nose and it's going to vasoconstrict. Interesting, huh? Okay, so what are we going to do? Basic first aid is pinching with the head forward 5 to 10 minutes. Why wouldn't we do back? I mean, everybody always wants to go back. Tilt your head back. Now, if we think about it, it really doesn't make sense why we'd go back. Because if you go back, what happens? The blood's going to go down into your throat, possibly into your lungs if you have any kind of a gag reflex problem. So we don't really want to go back. We want to go forward so the blood is going out, not rather in. This is one of those sayings, out is better than in. You're gonna pinch right before the cartilage, because if you pinch in the cartilage, what's going to happen? Nothing. You're pinching the cartilage. Might be a little painful, but basically you're not going to get anything done. So we're going to pinch towards the tip of the nose, as you can tell I'm doing that as I'm talking to you, and then we're going to apply ice for vasoconstriction. Makes a little bit sense, huh? Topical vasoconstrictors, like I talked to you about, is cocaine and neosynphorin. Chemical cauterization, silver nitrate, gel foam, and then we can do nasal packing. There's actually a packing that they call a rhino rocket, and it was kind of funny because we had a doctor and we kept on having a patient with nosebleeds. Couldn't stop her nosebleeds, and asked the ER docs to come up and do the rhino rocket. ER docs wouldn't come up. They were too busy, whatever. And so finally he Googled how to do a rhino rocket. He went in, did the rhino rocket, came out. So proud of himself. He said now he's ready for cardiovascular surgery. I think cardiovascular surgery is a little bit more in depth than a rhino rocket. Okay, nasal trauma and fracture can result in deviation of septum soft tissue trauma. So if you ever notice anybody that has a broken nose or any kind of nose damage, usually gets black eyes. If you watch the Kardashians possibly, or if you watch any kind of show that shows plastic surgery, anytime they sit there and they have anything done with their nose, they end up with black eyes. Major treatment goals is to identify what's happening, and we want to manage it. Okay, we want to prevent deformity. So signs and symptoms of any kind of nasal trauma or fracture is epistaxis, deformity, crepitus. Do you guys know what crepitus is? Crepitus is kind of like Rice Krispies under the sun, or under the skin. Kind of gross at some points. Periorbital edema, ecdymosis, nasal bridge instability. Treatments, we can reduce them. A lot of broken noses we don't generally do anything with, but you can reduce them, do an external splint with ice to control edema and bleeding. And in some cases, you might have to go to surgery. Usually you don't, though. A septal hematoma increases risk for infection. Remember, it's very vascular in there. So if you have any kind of hematoma going on, you got to watch out for that bacteria. Because remember, any kind of, let's say, sized hematoma, that's blood that's going to be dying in there. And the bacteria is just going to have a heyday going in there and creating more little bacteria. So we got to take care of that. Nursing care, we're going to elevate head, right? Because we want them to be able to continue to breathe. This is not the time to lay anybody flat. In fact, when you talk about cardio and respiratory, I don't think there's really many times you can lay anybody flat except after a catheterization. We're going to assess for CSF leakage. What do you think CSF leakage is? I'll give you a minute to think. Da na 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 na. Dun 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 boom boom. CFS leakage is cerebral spinal fluid. So what do you think that's going to look like? It's going to be clear. So if you have a patient that had some face trauma, nasal trauma, and they have clear liquid coming out of their nose or their ears, that we're talking about cerebral spinal fluid, and that is a very critical patient. Okay, we're going to avoid straining, blowing our nose, or vigorous coughing. We're going to avoid it. Now, of course, if you have somebody that is coughing, we're going to try to give them some lunges to get them to quit coughing, but sometimes that doesn't help. We're going to ask them not to blow their nose, but if they have a cold, they're going to blow. Ice packs, oral care. Why oral care? Remember, it's so vascular in your mouth and your nose. We don't want any bacteria to have the opportunity to get in there into that broken skin and just produce many, many, many other bacteria. And education on safety measures. So what could an education on safety measures be? Well, I guess if it is a skateboarder, you could tell them to wear a helmet. I mean, it doesn't help their nose, but hey. Or we can tell them maybe it's not a good idea to skateboard because obviously they're prone to injury. Or if it is a certain county, I wouldn't say Clinton County, let's say Jefferson County. We're going to tell them that if they broke their nose because they were in a ballroom brawl, to stay away from barroom brawls. Stay away from bars. You might be a better person that way. Okay? Or might not, but anyway. No. Okay, allergic rhinitis. So what's this? Some people call it hay fever. Some people call it those damn sinuses. It means you're allergic to the things that are going on in the air. Usually happens in spring or fall. Usually severe attacks related to environmental pollens, trees, and grasses. If you ever noticed that on the weather, I typically don't watch the weather because they're always wrong, but they'll tell you what the index is for the pollen and the different pollens. So if you know what you're allergic to, it kind of helps. Sometimes it could be year-round. Exposure to dust, dust mites, animal dander, right? We have so many now, what would you call, designer animals that have less dander, and cockroaches. Not really cockroaches in themselves, but people are allergic to cockroach poop. Imagine being told that the reason you have bad sinuses is because you have cockroaches and you're allergic to their poop. Symptoms can be mistaken for cold and sneezing. So you might think that you have a cold, but it could be an allergy. So it's kind of like one of those things. If you keep on doing it year after year after year, you might want to go take a look at your doctor and figure out what you're exactly allergic to. You can have itchy, watering eyes, may become congested, develop chronic irritating cough, and postnasal drip. Now, postnasal drip is usually what causes that irritating cough because it gets to the back of your throat. It also causes you to have that sore throat. So what are we going to do? We're going to do antihistamines, decongestants, nasal corticosteroids, and allergy testing and shots to stay away from what you're allergic to. Hold on. Okay, so upper respiratory infection is also called the common cold. Back in the day when I was a child, everything was a common cold. Then it seemed like we needed to be more politically correct. So when people say, oh, you just have a cold. No, you could go around and say, no, I don't have a cold. I have an upper respiratory infection. Either way you look at it, it's a cold. Okay. So it's usually viral. So what does that viral mean? Viral means that there's nothing we can do. We could basically suck it up and get on with our lives. We do everything we can for the symptoms. Hopefully it works. Sometimes it doesn't. I think that's why like NyQuil and Tylenol, PM, and everything, Sudafed, everything we use just to control the symptoms of it. We don't cure it, although now there's things on the market. I'm trying to think some of the ones that go away. Is that what it's called? That stuff that shows you in a plane and you take it because you start to feel a little bit of a cold. You take it and all of a sudden you feel so much better. I have to do research on it. I'll get better at this. Sorry, guys. Anyway, so you take the pill, but then they tell you that if you don't take it within the first couple of days of your symptoms, then it's not going to work. So most what do you think is the best way to stay away from having a common cold? Think about it. It's pretty easy. I'm not saying it's foolproof, but it does cut down on it a lot. You're right, it's washing your hands. So every time you touch a surface, it's good to wash your hands. I mean, hand washing, because what happens? You get the germs on your hands, and then you go for, I don't know, like a potato chip or something, you put it in your mouth, and boop, it goes on the potato chip, goes to your mouth, and guess what? The virus is in your body, and it's just going to make you miserable. Anyway, the common cold peaks between September and January, though there are times you have a cold during the summer. More than 200 strains of the virus can cause your upper respiratory infection. Spread by droplets or direct contact. You know, now everybody sneezes into their elbows, right? We used to always sneeze into our hands. You know, cover your mouth, sneeze into your hands and call it a day. But what happens? What do they figure out? You sneeze into your hands, you wipe it on your pants. Come on, you know you guys did. And then you go and you touch the doorknob. And then comes around somebody else and they touch that same doorknob, and next thing you know, they are, I'd hate to say potato chip, they're going to eat an apple. Yeah, that's healthy. So they're going to eat an apple, and they touch the apple, and that germs go onto their hands. So the virus, not germs, the virus goes onto the skin of the apple, and guess what they do? They eat the apple. So next thing you know, boom, they're feeling like crap. Contagious a few days prior and after the appearance of symptoms. Okay, manifestation, erythematous mucous membranes, nasal congestion, cortia. Cortia? That's profuse nasal discharge. That's that gunky stuff that's not clear. It's that yellowish, mucish, nasty enough. Sneezing, coughing, sore throat. Sore throat's from post-nasal drip. Low-grade fever, muscle aches. Symptoms can last up to 2 weeks. And I swear I've had a cold for a month, though, and can lead to other upper respiratory infections. Treatment, over-the-counter medications, rest and fluids, right? All you guys that were hacking all over the classroom. There's no rest in nursing school, is there? So there's some herbal remedies: echinacea, garlic, vitamin C and zinc, and aromatherapy. Some people really think about that aromatherapy, those essential oils. They really put a lot of stock in it. I've never done it, so I don't know, but Walmart's carrying it now, so I guess it says that it's doing good. Okay, so what's going on with respiratory infections in children? Infection rate increases after 3 to 6 months as the disappearance of maternal antibodies. Anatomically different, they have smaller diameter of airway, short distance between structures allow rapid movement down respiratory tract, right? That bacteria, virus, it's like viral superhighway down into the respiratory tract. Children between 6 months and 3 years react more severely to infection than other children. Isn't that the truth? Their immunity isn't really up to where it needs to be. And back in the day, they had, kids weren't allowed out the first couple of months of life because they thought that, you have to keep them away. Their immunity is weakened, and you don't want them out in the public and catching cold or catching a death, as they would say. Of course, that's changed now. I don't know if that's for the better or for the worse. People take their day-old babies out to Chinese buffets. Not saying that's good, not saying it's bad. So then we got into a part where it was passive immunity. And I was on that horse, or that club, that passive immunity club, that, I don't need the flu shot, I don't need this, because, I have all that exposure at the hospital, or when I was working at Aldi's or Eaton Park, that when I come home, I'm giving little doses of that bacteria and stuff to my kids so that they would build up this immunity. Yeah, I don't think that works quite as well either. We like to think it does, but I would say the safest bet is to wash your hands, try to keep your kids away from other sick kids. I mean, they're probably going to get it, but I'd rather somebody else's kid be sick than my kid, although that seems kind of wrong in so many levels. Just a cold, that's what I'm saying. Because if you knew my kids when they were sick, holy moly. Okay. So, what would we find in the kids? They might have a fever. They're not going to eat. They can have a fever as much as 103 to 105. And boy, doesn't that just stink for us. Not only for the kids, but for the families. Listless, irritable, or they could not even care less and just keep on being active. Children vomit readily with illness, and that is a pain in the butt. Because what happens is they start coughing, and because their whole tract is a lot shorter than in an adult, they're more prone to throw up. They're going to vomit. So what happens in school? They cough, cough, cough. They vomit. Next thing you know, your kid's out of school for 48 hours. It's a pain in the butt, especially when you know the reason they coughed was, or the reason he threw up because it was a cough, not because of a sick stomach. But that's the school rules, and you will drive, like I did, 2 hours to get your kid just to pick him up, and him smiling and being happy he can come home with you instead of staying in school all day. Yeah. Anyway, sore throat among common symptoms in younger children that are not able to communicate will refuse to eat and drink. Okay, RSV, primary cause of respiratory illness in young children, lower respiratory disease in infants. It can range from mild in older children and severe in infants and immunocompromised. Spread by droplets and direct contact. Incubation period is 4 to 6 days. So before it even comes out in the open, it is harboring and festering and producing all kinds of viral strands in the body before the symptoms start to show. Manifestation in the adult is the same as an upper respiratory infection. It can progress to pneumonia and bronchiolitis, especially in the infants. Hydration, mobilization of secretions are key. So we're going to keep them drinking. Problem is, when you're talking about respiratory problems in kids or adults, what's going to happen? They're going to cough. Every time they take a drink, they're going to cough. Are they going to drink as much as they're supposed to? Probably not. I remember in Rita's class, every time somebody coughed, she would tell them to drink. And what's that doing? It's thinning the mucus so that they're able to cough the crap out of their lungs. So what are we going to do? You're going to see whenever somebody comes into the hospital, pneumonia, bronchitis, whatever, we're going to hook them up with fluids. Okay, and that's the main difference when you're talking about somebody coming in with pneumonia and having chest pain, or coming in with an MI and having chest pain. The person that's having pneumonia, we're going to hook them up to IV. What we want to do is thin out those fluid, or thin out the mucus so that they're able to cough it up. Okay, we can give them an antiviral, can progress to intubation and mechanical ventilation when severe. You know, people are put on respirators, ventilators, due to the fact that they have RSV. Of course, those are more the immune-compromised people. They have something else going on, you know, whether it's lupus or cancer, something else is going on that it progresses to that point. Okay? Okay. Influenza. Oh, God, we're in that flu type of year, aren't we? Highly contagious viral respiratory disease. And it causes deaths. Never thought the flu would cause death. Did you really? But it does. Mild cases are self-limited, but can have deadly consequences for high-risk populations. What's your high-risk populations? We're talking about the elderly, the immune-compromised. When we talk about the immune-compromised, what are we talking about? Well, we're talking about lupus. We're talking about scleroderma. We're talking about HIV, patients with AIDS. Anybody basically that's on a steroid. So your patients that have had transplants will be that risky population. Also, people with COPD that are on steroids will be in that high risk population. So we really have to watch out for them. I remember I was totally against the flu vaccine because of the fact that, well, why should I get it? I have passive, resistance. I deal with these people all the time, blah, blah, blah. Till Deb Manning sat there and said, oh, okay, so when you're taking care of your oncology patient and you give them a flu and you kill them, how are you going to feel? Well, crap, that made me just roll up my sleeve and give me the damn flu shot. When you put it like that, yeah, it makes me feel bad. So anyway, then they started mandating and we all get flu shots no matter what. And well, I guess I was one of the pioneers of getting flu shots. Okay, there's 3 subtypes, A, B, C, and A being most dangerous. Okay, let's see. Manifestation, the coryza, cough, substernal burning, sore throat, Systematic is fever, chills, you feel like crap, muscle aches, and fatigue. Complications can go into pneumonia, exacerbation of COPD, and we'll talk about that. Sinusitis, Reye's syndrome. And the reason for Reye's syndrome, people used to give aspirin to their kids, hence the name baby aspirin. And actually, whenever I was a kid, it tasted pretty good. It was this orange flavored aspirin that you would chew, and I kind of liked it. But anyway, they found out that all these kids that were given aspirin got Reye's syndrome. They would give them the aspirin just to bring down the fever. And of course, it led to hepatic failure and encephalopathy. Which, I guess that you can say I got lucky, big time. A lot of kids weren't that lucky. But that's why we call it a baby aspirin, because that's what we used to give, baby aspirins. Prevention, immunizations at risk populations with polyvalent, many strains of vaccine, 85% effective. 85 is better than none. And what do? So they go around, and it's 85% effective due to the fact that they don't know what the strand is. The strand doesn't exactly go to the CDC and say, hey, this is what we're going to do next year. No. It's whatever, they have to kind of do scientific measures and statistics on what strain they think is going to be the big strand of the year. And that's how they figure out what your vaccine is going to be. Okay, at-risk populations, over 65, adults and children with cardiopulmonary disorders, diabetes, healthcare workers, pregnancy, families of at-risk populations. Contraindicated with egg allergy, but now we do have vaccinations for those that are allergic to eggs. Live antenated may be given to healthy people under 50. So, that being said, what does that mean? That means that anybody that doesn't have the above problems, okay, cardiopulmonary disorders, diabetes, healthcare workers probably can get the live antenated, but pregnancy, who else? So, your COPDers, your asthma, anybody over the age of 50. So we're talking about people that are immune suppressed. We don't want to give the live attenuated vaccine, okay? Because of the fact that if we do that, it could possibly break out, right, into pneumonia or into influenza. So you might want to remember that, okay? So if you're a walkie-talkie, healthy healthcare worker, you can get the live vaccine. If you are a COPDer or you have other immune problems, maybe you're on a transplant, you had a transplant and you're on corticosteroids, you would not be able to get the live attenuated ones. Possible complications is Guillain-Barré, and we talked about this a little bit in class. It starts out like flu-like symptoms, and then people get paralysis starts from their toes and works their way up. And if we don't catch it, they're going to basically, their lungs are not going to be working because it deals with the nerves and the muscles. There is a reversal agent, but a lot of times people don't think about it. It usually happens in the 30s and 40s that people get it. It is a possible complication that if you have the live version, that you could get the Guillain-Barré, whatever you want to call it. Medications. We have Renaleza. Basically, what you're going to see is Tamiflu, though. But with the Tamiflu, you have to give it within the first 24 to 48 hours of having the flu. If you don't, it's not going to do you any good. Okay. They're given, let me see, Relenza or Virozole are given via inhalation, may precipitate bronchospasm, so not recommended for patients with COPD. So basically patients that are compromised in their lung bases anyway, we don't want to mess with it. Should begin treatment within 48 hours. And symptomatic relief, acetaminophen, NSAIDs, and antitussives. So the Tamiflu is probably the best bet you have, whenever you have the flu. Of course, they'll give you antibiotics because they don't want to make it into a pneumonia process, but the Tamiflu is the fastest. Okay. Sinusitis is inflammation of mucous membranes of one or more of the sinus cavities. Commonly follows your upper respiratory infection, typically viral. Bacteria could be strep, staph. Other contributing factors are nasal polyps, deviated septum, rhinitis, and tooth abscess. Why do you think a problem is nasal polyps, deviated septum, or rhinitis? Let's think about this. Well, the reason, because the nasal polyps and the deviated septum, even the rhinitis, is because you're not allowing the bacteria to exit the nose. It's kind of like keeping it up there a little bit longer than it needs to. So what happens? It's nice, warm, right? Little bit of wetness, and the bacteria are going to have a heyday. What about tooth abscess? Because the tooth are so close to the sinus cavity, any kind of bacteria that can grow and permeate into that sinus cavity would cause a sinusitis. It could be acute or it could be chronic. Manifestations: pain and tenderness over affected sinuses, headache, fever, malaise. Symptoms often worse in first few hours after waking. Nasal congestion, purulent nasal drainage. Yum. Bad breath. Why bad breath? Well, the bacteria in your mouth is what causes a bad breath. Not necessarily the garlic toast you had the night before, but it's the bacteria that's involved in your mouth. You're going to have also red swollen mucous membranes. Medications, we're going to give an antibiotic, okay, for 10 to 14 days. Remember, we're supposed to finish all of our antibiotics, and as part of the patient teaching with the antibiotics, we're going to tell them to get some yogurt, right? So they're going to have yogurt so they don't get C. diff from this. Okay, we're going to do Augmentin, Bactrim, Ceftum, or Cipro. I would imagine the first line of treatment would be the Augmentin. Okay, going to go oral, topical, spray decongestants. Now, what we want to tell our patients is with decongestants, if they do the topical decongestant sprays, that we're going to tell them that not to continue the decongestants until they feel 100% better. Okay, it could cause more harm than good. We want them to use the decongestant so they're able to breathe and do their activities of daily living. We don't want them to continue to do it, because what's going to happen eventually is you're going to have almost like I don't want to say a backup or a backlash, but you're going to have it, your system is going to play havoc because it's used to giving, wet mucous membranes. And if you do the decongestant, it's eventually going to overcome that decongestant and get really totally used to it. And then it's not going to work anymore. Okay, nasal steroids. Remember, steroids decreases inflammation. Decongestants decreases mucus production. So it brings down the inflammation. Okay. Saline irrigation, nose drops. Saline irrigation. Did you guys ever hear of neti pots? Some people just love those neti pots. And basically you use those neti pots. You can make the saline at home, or you can get it over the counter. And you put the saline in the neti pot and you just stick it up your nose and then get it out. Some people really like that, it's a homeopathic type of situation. Okay, systemic mucolytics like guaifenesin, like when I think of it, I think of Mucinex, okay, or surgical treatment. If it's a continual problem, then we're going to get rid of those nasal polyps and do something about that deviation. I was in front of you guys. Okay. So, red throat, possible exudate or white patches on the tonsils, malaise, although I just said that. So, the kids might have sore throat, they might not have sore throat. What do you think is one of the main reasons or the main people that find out about tonsillitis? Who diagnoses tonsillitis? Let's think about this. Regular doctor can. That makes sense. But who else do you think can diagnose tonsillitis? How about the dentist? You go into the dentist's office and you have really bad breath, and it's not simple chronic halitosis. What happens is the bacteria in the tonsils are festering and causing bad smells coming out of the mouth. And guess what? Tonsillitis. You gotta get rid of those tonsils before they cause all kinds of problems. Another reason people get rid of their tonsils is for sleep apnea. Sometimes their tonsils are so wide and so big that they obstruct the airway whenever they're sleeping. So it would cause sleep apnea. So they get rid of the tonsils as one of the first, especially when you're talking about children, one of the first, let's say, interventions for the sleep apnea. Also, something that's kind of cool that I found out while I'm teaching this class is called tonsil stones. Any of you guys have tonsil stones? Well, I was lucky enough to get a tonsil stone from one of my students from the last 8 weeks. So basically, these tonsil stones are stones, kind of like calcium. They're calcified in the tonsils. And look it up. You can YouTube it, Google it, whatever you want to do, and you can see these tonsil stones, and people go in and use usually like Q-tips or something to that effect, and they can poke out the tonsil stones. Like I said, I got one, so I get to show it to you. It's not really big. I'm waiting for her to produce some big ones. She's in Lisa's class, so if she gives me a real big one, then I'm gonna get GEP point for her for her contribution to science. But anyway, I also had a student last year that she was getting so many tonsil stones that they decided to finally remove her tonsils, and it took so long because of it. And what you hear is that when you're a kid, tonsils suck, getting them out. I never had them done, knock on wood. I had my two daughters got them out. They were supposed to get them out the same day, which looking back was a stupid thing to think of. But Abby ended up having a fever, so she went a week after her sister. Katie did great the first day because everything was still numb. After the second day, oh my Lord, it was horrible. My 16-year-old, boy, do I have stories about her and anesthesia. Her and anesthesia just don't work together. They put it this way, as a mom, they called me down to recovery because she was a mad woman. And she was only like 7. And she was a mad woman. It was awful. I still have nightmares. Ugh. But anyway. And I thought that was bad. But it turns out that if you get tonsils taken out as an adult, it's a little bit worse. It's a little bit longer of a healing time. It hurts a little bit more. I'm not exactly sure of it, but anyway, that's what they say, and that's what she said. She didn't think she was ever going to feel better after her tonsil surgery. Okay, complications, peritonsillar abscess, scarlet fever, rheumatic fever. Remember, rheumatic fever? Don't want that. So we're going to finish all our antibiotics because we don't want it to hurt our heart. And acute post-streptococcal glomerular nephritis. How about that? I said that pretty darn good. Anyway, those are the complications. Diagnosis and treatment. We're going to do a rapid strep swab. At least 10% are false negative. We're going to do a CBC because we're going to look and see what the white count is. Drainage, peritonsillar abscess with possible tonsillectomy. Follow up in approximately 6 weeks. Post-op tonsillectomy, assess for bleeding up to 2 weeks post-op. There was a situation a couple of years ago where a little girl bled. Her parents were calling for help. Post-op, nobody came and helped. The girl choked her on her own blood, and she ended up becoming brain dead because of it. Because of that, well, even before that, you're not allowed to give any kind of red food or juices because we want to make sure that we recognize it's blood. We're going to ensure the patient's head airway. We're going to elevate the head, liquid, soft diet. This is not the time to be eating anything rough. Remember we talked about the potato chip going down and not chewing and how it hurts all the way down? Yeah, not a good thing. They get to eat ice cream. If you watch the Brady Bunch, when the mom and I think Cindy got their tonsils out, they got all the ice cream they wanted. Well, this is the time where the kids get to have as much ice cream as they want. Ice collars and warm saline mouthwashes. Okay, we don't want to do alcohol, right? We want to do saline because we want to be nice and warm. We don't want to dry it up like the alcohol does. Alcohol would burn it and possibly cause it to start bleeding. Epiglottitis. You don't see it very often, but basically what happens is the epiglottis swells shut. Okay, it's a medical emergency. What are you going to see with a patient like this? They're going to be drooling. They can't swallow. They can barely breathe, and they definitely can't swallow. Okay, so they're going to be in a tripod position. You're going to hear how hard it is for them to breathe. Okay, they're going to have a sore throat, but basically you have to get this kid to a facility that can take care of this, okay? They're treated with IV antibiotics, and we're going to watch them very closely, okay? Because this is a dangerous situation. Laryngitis really, it really has to do with nothing. You know, when you have laryngitis, it's because you've been yelling too much, screaming too much. When you go to a concert and you're singing too much, signs and symptoms are hoarseness, sore, scratchy throat, dry, harsh cough. Treatment: chill out, rest your voice, rest your throat, and you should be better in a couple of days. Toxins released by bacteria paralyze cilia. I kind of touched on it, but I never went through it. So when I say about the cilia being very important, without that cilia, everything's going to go back into the lungs. Okay, so that means any kind of bacteria, any kind of foreign substance, any kind of smoke, any kind of, trying to think of anything else. Anything in the air can go right. That cilia, what it's there for is a trap to kind of protect the lungs, right? They're kind of like the gatekeepers of the lungs. They keep things that are coming into the lungs, and it's like kind of like a gatekeeper. It kind of like holds things at bay. When they're paralyzed, they're not doing their job, so things are having a straight line right into the lungs. There's no pass and go. I mean, it is going into the lungs. So that's why the cilia is so important in this aspect. Okay. So this leads to inspiratory and expiratory difficulty, leading to substernal intercostal retractions. Child becomes hypoxic, restless, and desperately anxious. Bark like cough. Okay. So they're going to use every muscle they can to be able to breathe, okay? And unfortunately, unless we stabilize the patient and we support the patient, this could be, okay? They're going to do high humidity, cold mist, O2. We're not going to give them just dry O2 because what's it going to do? It's going to dry those membranes out. What we want to do is give them a nice cool mist, right? So that those membranes, we lessen the mucus. We can thin the mucus out so they're able to cough it up. Encourage fluids, IV fluids, okay? Increased heart rate, restlessness, severe stridor, use of accessory muscles. We're going to monitor them, and oxygenation and ABGs. Okay, so we're going to keep a close eye on their SATs. Obstructive sleep apnea. Leading cause of excessive daytime sleepiness can become potentially serious life-threatening problem. Risk factors are male gender, increasing age, obesity, large circumference of neck, use of alcohol and depressants. So it's been such a big push about sleep apnea that now whenever somebody comes in and they look like they have a larger neck, we have to measure the neck and put them on sleep apnea precautions, OSA precautions. So what do you expect to hear from these kind of... Okay, loud snoring during sleep. Number one sign, okay? If you can hear the patient sleeping from or snoring from the nurse's station, it's fair to say that they have some sleep apnea. Excessive daytime sleepiness. But you know what? They might just say they're sleepy because they didn't get enough sleep. Well, the reason they didn't get enough sleep is because every time they stop breathing, they kind of wake up. So they don't have that good REM sleep. Headache, irritability, restless sleep. Periods of apnea can be 15 to 20 seconds, okay? So what happens is they stop breathing, and then they gasp, and they wake up again, okay? They might not wake fully, but they wake up enough to disturb their sleep. Gasping, choking during sleep, personality changes. It can be linked to hypertension, ischemic heart disease, exacerbation of heart failure, impotent and intellectual impairment. I'd get this done a lot quicker if people wouldn't stop interrupting me. It's what you do for doing this at home. But anyway, linked to hypertension, ischemic heart disease, exacerbation of heart failure, impotence, and intellectual. Okay, complications. Increased workload of the heart may lead to. So the heart's having a hard time keeping up with this sleep apnea, okay? Because what happens? You stop breathing, your heart's going to feel like it has to work a little bit harder due to the fact of getting that oxygen into all the different places in your body. So myocardial ischemia and angina could happen. Dysrhythmias, right? The heart kind of freaks out and it gets tired of freaking out. So what can you go into? VFib, VTAC, right? Heart failure, sudden cardiac death, and pulmonary hypertension, okay? Because your heart's not pumping like it should, it's going to back up the plumbing system. Diagnosis and treatment, polysomnography. So what they do, we can't even do it at the hospital. We have to do it in a sleep lab. And I had to go through a couple of these with my daughter. And you get there about like 7 o'clock, and they hook you up with the EEG. They have bands around your chest to monitor your respirations. They have your SpO2, blood pressure cuff, all kinds of stuff to know everything about your whole sleeping process. And then at 8 o'clock, they decide to turn the lights off, which really kind of stunk because I'm not used to go to bed until about 11 o'clock. And they sit there and they watch you sleep, basically. And they monitor your EEG. And then about 6 o'clock, they wake you up. Which is okay, I guess. Except they don't offer you a shower or anything like that. So when you're stuck in Cardinal Glennon and you have a bedhead, it's just not a fun time to walk out of the room, that's for sure, into the public. Okay, so they decide about what kind of sleep apnea you have. Okay, so they look to see what kind of sleep apnea you have, if you even have sleep apnea. And they go over the results with the doctor. Well, then you have to go back and they talk to the you talk to the doctor, and there could be certain things like weight reduction. Weight is a big thing when it comes to sleep apnea. Okay, it's kind of like overweight. You look at diabetes, mellitus. Well, that's the same thing with sleep apnea. Okay, alcohol moderation, avoids sleeping totally flat, and oral nasal appliances. I think you've seen them on TV where you put the little thing over your nose, breathe right, and then you'll stop snoring, things like that. So say you did all that, and the doctor's not real happy because you still have this sleep apnea, because you have to go back. You know, even if say you lost 10 pounds, it's not good enough, so then you go back and they say, yep, you still have sleep apnea. Well, then you go back to the sleep lab and they try different appliances on you. Okay, so they'll try the CPAP, and there's different different masks you can use. There's a little piggy nose where it's just two little tubes that go up your nose and make your nose look like a pig, which is totally unflattering for anybody. Or there's just a mask that goes over your nose, and I mean there's so many different types. So you'll go and you'll try out these different masks, and they will continue doing the sleep apnea test until they have it perfect, what your settings should be on your CPAP. Let's see, some settings you have on your CPAP or BiPAP, but most of the people with sleep apnea are on their CPAP. If that doesn't work, then you will have to go for surgery, and it's a uvulopalatopharyngoplasty. I think I did that pretty good. That's a UPPPP. So basically, they do a rotor-rooter, and it's a big dang surgery. So it's probably better to go and do with the CPAP. But unfortunately, like any kind of chronic disease, a lot of people don't like their CPAP. They don't like using it. It makes too much noise. I don't like it being in my head and blah, 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 blah. Okay, my wife doesn't like it. It's unflattering, or, you know, I sleep just fine. And they might think they sleep fine. Of course, they're not the ones that are staying awake while they're snoring. So it's one of those things that, you know, people say, yeah, I have a CPAP machine, but I haven't used it in forever. And basically, that was my daughter. She's going to kill me for saying this. But we went back and forth to Cardinal Glen and got the right CPAP, the right settings. And she would not wear that. I think I could strung her by her toes and she still wouldn't have wore it. Big waste of money. But anyway, not that I'm, what did I say? Not that I'm, I don't know, salty about it or anything. But anyway, with her, what they did was they found out that she had sleep apnea. And the first thing they did was they took out her tonsils. The second thing, but then they did the sleep apnea test after that, and lo and behold, she still had sleep apnea. What they found for her, though, is that when she sleeps, she goes into a deep, deep sleep. Like you go into sleep and you kind of go down to the curve, you know, go down this line to the base of your sleep where you're in deep sleep, but then you come back out of it. She never comes back out of it. That was her whole problem. That's why she needed the appliance, because she would go so deep into a sleep that she would basically stop breathing. I often said that if the house caught on fire, I could see her not getting out. Oh, sorry, I yawned. And I really truly believe this. She is the worst person to try to wake up. And when she does wake up, and you wake her up in the wrong time, man, you know it. But it's all because of that, how far deep into sleep she gets. Which, I guess you should wake up more rested, but I don't think it exactly works that way. So anyway, head and neck cancer. Most common malignancy is a squamous cell carcinoma. Pay attention to these risks, because I guarantee you will find them. See them again. Tobacco use, alcohol consumption, poor nutrition, human papillovirus, exposure to asbestos, radiation therapy, poor oral hygiene. Why poor oral hygiene, do you think? More men affected than women. So let's go back. We're talking about tobacco, which isn't a no-brainer. Alcohol consumption. Do you really think of head and neck cancer when it comes to alcohol consumption? Well, if you're an alcoholic and you drink so much, remember, there's a theory that your body contains cancer cells all the time. Okay, and it's just waiting for that opportunity to spring into life and procreate. Okay, that's why some families are more susceptible to lung cancer, whereas others, like you always hear, oh, my grandfather was 104 and never had lung cancer. Meanwhile, you have another family that they've had they've smoked for all their lives, and the whole family is getting lung cancer. And I kind of believe it. It kind of makes sense. So the same thing with alcohol consumption. You know, you're breaking down your body. When you break down your body, when you drink so much alcohol, that it's just going to have, cancer could be opportunistic, right? Kind of like you're on all kinds of antibiotics so that bad bacteria is able to flourish with C. diff, and thrush. Okay, so you have all this going on, and you're basically opening up your body for any kind of problems. Not only cirrhosis, but you're thinning the cells going down to your esophagus, right? And, well, guess what? You're opening yourself up to problems, and cancer finds out that it can procreate, okay? Poor nutrition, same thing. Your immunity kind of goes downward, right? HPV, just within the last couple of years, they started bringing out stuff about HPV is just not for women, it's for men, and then they give you this big commercials about how parents are bad if they don't get their kids vaccinated with HPV because they're going to get cancer later on in life. And I guess there's some truth to that. Exposure to asbestos, and we found that out the hard way. Radiation therapy, poor oral treatment. Why do you think that is? And I think it's about the same as everything else. You have a kink in the system. You have your armor is like there's a hole in that armor of your system, of your skin, and it's just the opportunity for the cancer to flourish. Okay, manifestations: hoarseness, change in voice, painful swallowing, dyspnea, foul breath, palpable lump in the neck, earache, leukoplakia, which is white flaky patches that are precancerous, and erythroplakia, which is red velvety patches in later stages. Let's go back though to the painful swallowing, or the hoarseness, or the dyspnea. But you're a smoker, you're going to sit there and say, oh yeah, that I have a sore throat because I smoked too many cigarettes, or I cough because I smoked too much cigarettes. I need to cut down. You can explain away a lot of things. Or you have a sore throat, and maybe you're not a smoker. Maybe you just drinking alcohol. Well, it's just a cold, post-nasal drip. Might not have any nasal problems, but I have post-nasal drip. And that's, people like to explain away things, okay? And I don't blame them, but that's what they do, okay? And that's why it's not found as fast as it could be. Okay, we're going to do direct or indirect laryngoscopy. So basically like an EEG, we're going to go down and look, do a bronch possibly, and look to see what's going on down there. We're going to biopsy it, and that's during the bronch or laryngoscopy. Imaging studies, CT, MRI, and PET. Okay, treatment depends on the stages and what we're going to do. We could do radiation, brachytherapy, which is typical choice for early laryngeal cancer. Okay, preserves the preserves the voice when possible, and we'll use it with chemo and surgery. Then we have chemo and surgery. Now laser laryngoscopy, early tumors may cause trauma to the voice cords, voice rest following surgery, and may require temporary tracheostomy. We're doing a lot more with lasers, and if it's doesn't involve too much of the tissue, then we're going to try to do with the laser, because it's a lot quicker path to go in, and it's a lot less invasive. Okay, then we have laryngectomy. Okay, localized tumors. This is a partial. At least 50% of the larynx is removed. Voice preserved. They'll have a temporary trach, and we will do feedings, enteral feedings post-op. Now, let me go back a little bit. When we're talking about these cancers, one of the first things we're going to do as part of the interventions is get them a feeding tube. Okay? The reason we're going to do a feeding tube is we want them to have the nutrition to combat the chemotherapy, the surgery. Okay? We're not going to do, oh, let's do a partial laryngectomy and, oh yeah, by the way, then we'll start the feedings. No, we'll get them used to the feedings. Okay? Probably give them a couple weeks because, you know, by the time they get to us, they probably are a little bit on the less nutritious side anyway. Okay? They probably lost a couple of pounds. So we want to boost up their immune system and make sure they're able to withstand the problems that they might encounter. Okay, total laryngectomy, cancer expanding beyond vocal cords, entire larynx, and surrounding structure removed. Normal speech is lost, permanent tracheotomy. So they'll always have a trach. Not saying that they're going to always have a trach and on a vent. And I'm sure you've seen these folks walking around, Buckeyes, Schnooks, you know, they have a little hole in their throat. And I'm sure you've seen it on TV when they're talking about smoking. They have the little voice, you know, he's shaving. Make sure you don't shave over your trach hole and don't look towards the shower. You know, you have to have your back to the shower. They have little voice boxes, that little mechanical ones that can help them talk again. Now, with these people, are they going to be able to eat normally? Or are they always going to be fed? It is quite possible that they are going to be able to eat after everything's said and done. Okay? Radical or modified neck dissection. It is a huge surgery. Cervical lymph nodes involved, all soft tissue from lower mandible to clavicle are removed. It's a heck of a lot of surgery, and I really should get a picture to post so you know what it kind of looks like. May result in significant deformity, requires grafts and flap. They're basically taking a lot of the neck. Okay. We're going to do an informed consent, of course. We're going to educate them on what to expect post-op. You know, this is a big dang deal for these people, right? So they're going to totally lose loss of speech. We need to establish before they go to surgery how we're going to communicate. Okay? Because think about it. If you're not able to communicate after surgery, how would you feel that you can't communicate your needs? That would have to be so frustrating. Okay? Surgery will affect sense of taste and smell and breathing through the stoma. Okay, emotional support. Whichever one it is, we have to give them emotional support. Just being there. Not to be afraid to go in there. Okay, like, oh, I don't know what to say, so I'm not going to be in there. Be there with the patient. You don't necessarily have to make small talk. You can chart in a room. Let them know that you're there. Okay? Let them know that you're there to help them as much as you can. Okay. We're going to monitor the airway. We're going to turn, cough, and deep breathe, elevate head, humidified O2. We don't want that dried. You know, if they're on O2, we don't want those mucous membranes to be dry and start bleeding. Hydration, suction trach, use sterile technique. Do we have to go through suctioning or trach care? Now remember, it's sterile technique while they're in a hospital. When they go home, it's not necessarily going to be sterile technique. Okay, tracheostomy care, dressing changes, support head and bend when moving. In bed, frequent communication with patient. Don't be afraid of these patients. Go talk to them. Treat them like they're human beings. They got to relearn swallowing techniques. So who does the swallowing? Speech therapy. So speech therapy will be involved in all this, and dietary modifications.